feature for me saying set intro. Hello, Dr. Shilpa McQuillan. How are you from the Berkshire Menopause Clinic, NHS GP, community gynecologist, all-round expert on anything that happens below the belly button? How are you?
I'm good, thank you. Thanks for having me again. How are you?
Well, I'm all right. I seem to be putting out fires on many fronts at the moment with all sorts of FDA things going on about black box warnings being removed when they hadn't, and lack of process, and God only knows what else. So I feel like I'm in a little bit of a political toaster.
Yes, but one of my favourite subjects. So it's on vaginal estrogens, isn't it? Which is one of my faves. So yeah.
Yes, there can never be a conversation without vaginal estrogen.
Yes.
The things that I happen to have next to me every day, but that's not what we're talking about today.
This is what I've got next to me today.
That is far more exciting, because what we're talking about is endometriosis with a little bit of adenomyosis slapped in there as well. And yes. This is probably 1 in 10 people, 190 million people around the world, and that's probably a massive underestimate for the number of people who've told your periods are normal. So what is it, and what does it do to people?
Yeah, really good question. So I'm going to just strip it all back and start again, as I always do, as you know. So I've got my trusty little model, so I have to work around how the mirroring works on these cameras. So this is my womb. And I'm just going to, would it be helpful? I'm just going to talk through, because I think visual aids really help, don't they? So for people that don't know, and please don't feel patronized if you all know this, but these are the ovaries. This is the womb, this is the cervix, this is the vagina. Okay. Now this womb is made up. Sorry, I'm trying to navigate because the camera is the opposite way to my mirroring. This is out inside of our womb. This is the endometrium, which is the womb lining. This is the myometrium, and then there's the perimetrium. So we've got 3 main layers. Okay, it's a bit more complex than that, but 3 main layers. So what is endometriosis? Why I'm telling you this is it's really important. Endometrium is the official word for the womb lining. So endometriosis is basically where we get areas of womb lining deposits outside of the womb in other areas of the body. Okay. And these areas could be other areas of the actual womb itself. And this brings us to adenomyosis. So adenomyosis is where we get endometriosis, like in the muscle layers of the womb. Okay, so you're getting inflammation within those areas. You may get it within those areas, so you get adenomyosis. You may also get it on, for example, the ovaries. You can also get, you can pretty get endometriosis anywhere in the pelvis. So your ovaries are common areas, and within the womb layers, so your adenomyosis are common areas. And then outside of that, of course, you've got anywhere in that space in the pelvis. So that could be near your bowels, near your bladder, floating around in the pelvis, causing inflammation and fluid. And actually, for some people, it can go further, more distance. So for example, scar tissue, wherever, whether it be in the pelvis, but you might have a cesarean scar, you can get scar tissue, or even really serious for some people, the lungs.
Yes, I've even heard of it in the brain as well.
Yeah, absolutely. Because what happens is it can travel. If you think about, anything that kind of gets pulled off an area, it can travel, can't it? Be it through lymphatic system, through your blood system. There's different ways that it can travel. And so absolutely, you can get distance areas of endometriosis as well.
Wow, that's really interesting. That leads me to causes, because the way, I'm declaring absolute, complete and utter ignorance here. This is something I know very, very little about. But I was kind of under the impression that it was kind of like a genetic condition, and you were just unlucky that you were born with bits of tissue in the wrong place. But what you're saying is, no, they're picked up in a bloodstream and they're actually moved around and deposited into places.
Yeah, so endometriosis is so complex. If I can try and summarize what your kind of causes can be. So one of the things is what we call retrograde menstruation. So this is where our menstrual flow, doesn't it? It comes from the womb lining. We shed our womb lining. It comes through the cervix into the vagina and out. Retrograde is actually where there's a buildup of period that actually ends up going backwards into our pelvis. And I'll talk a bit more about actually the process of endometriosis and why it causes the symptoms in a minute. But if we just simply
goes up through the fallopian tubes and where the little fingers are that reach to the ovaries and sort of spills out that way.
The other reason is inflammation. So you can get changes to your cells. So if you think of it, and this is obviously not cancer, but if you think of it like a tumor, that there's inflammation and cell changes that can happen, that can also be a cause. And then having underlying immune conditions can also be an underlying cause as well. So what does that mean in terms of risk factors? Now, you mentioned genetics. Absolutely. So having family history may be, if you think about those people who say, my sister, my mum, my other sister, they all had endometriosis. Okay, that is absolutely a risk factor. Having a low weight can also be a risk factor. So your low BMI can be a risk factor. Then we talked about retrograde menstruation. So anything that causes outflow blockage. So people, for example, I mean, there's lots of anomalies you can get. So lots of conditions where you've got different anatomy. If you've got a blockage and your period can't get out and it flows backwards, then it's going to cause inflammation in your pelvis and lead to endometriosis as a risk factor. And then to put it really simply, anything that exposes you to more estrogen can be a risk factor. So what that means is you're more ovulatory cycle. So you're having an early period, you're having late menopause, you're what we call anulic, so you've never had a pregnancy. These are all also risk factors as well.
Okie dokie. And so then when we think about it, okay, once we've got to because basically the point of this talk when we get to it is managing it when we're on HRT. But to get to that point, when we're in our sort of before perimenopause, how do we manage it?
Yeah. Well, I think it's really important to know that part of when we manage it with HRT, I think the management is still very much the same, and that is individualizing it to those particular symptoms. Okay, so why don't we talk about what symptoms actually people get? Because the treatment does depend on that. And yes, HRT is part of that treatment depending on what happens. But also, even if you're going to give patients HRT, we still need to take a really holistic point of view of treatments, because there's loads of things in addition to that that can help. So if we think about what the symptoms are, now I've actually written down my symptoms because I didn't want to miss any of them, because there's so many, and people will scream at our screen saying that is actually me and no one ever talks about it. But let's talk about the common ones. Increased heavy periods. Okay, so you can get them. Painful periods, and not just painful periods in your womb lining, but obviously we've just discussed where it can endometrial deposits can go to, so you can get it in other areas of the pelvis, right? So pelvic pain. You can get chronic pain outside of your periods. And I want to talk about this a little bit more. Why does that happen? Because endometriosis is basically influenced by estrogen. Okay, so what happens is predominantly those symptoms may start with every time you have a period and that blood is being shed from your womb lining, those other deposits are also being shed and inflamed, right? So that's why you then get the symptoms that you're getting. So you can also get chronic pain. So if that's the case, why is it outside of our period time that do people end up with pain? And or any symptoms? The reason is because what can happen is over time, if you're just getting chronic stress on your body of that bleed constantly being in other areas of the body, which leads to inflammation, which leads to scar tissue, those things are more permanent. Yeah, they don't just happen cyclical. Scar tissue, it then becomes a permanent feature. And also inflammation does. So you're constantly stressing your body. And that's why you then get pain or other symptoms outside of just your cycle, of just the time of your period. And that's why then if you're getting that chronic inflammation, it leads to other symptoms, like people get mistakenly saying they've got painful bladder syndrome. Blood in your urine, it always been said to be urine infection because you've got urine symptoms, when in fact it could be endometriosis. People mistakenly be told they've got IBS or some kind of bowel problem. You can get blood in your stools. Yeah. Have you ever heard of bowel spasms? So this is literally when people go to the toilet and literally they're doing this because it's literally spasming. So this is where there's endometrial deposits in your rectal area. So little deposits, and it can cause bowel spasms as well. And not many people realize, again, that's put down to, could something else be going on? Have you got a fissure in your, around your anus or something? So those things, pain running down your legs. How many people have throbbing or shooting pains down their legs? And it's often not even thought of. This could be something going on, a nerve being entrapped from your pelvis. And that is a very common phenomenon with endometriosis, and it often gets missed. So you can see there is a whole host of symptoms, right? And let's not forget fertility. Some people don't present with symptoms. Some people present because the first point of call is they're trying to get pregnant and they can't. And then investigation then reveals endometriosis.
Well, this is the thing, is it could take, any up to 12 years, or perhaps even for people to get diagnosed. And they describe me, I mean, like poor, I'm probably going to massacre the poor woman's name, the BBC presenter, who was describing that she was wrapped around the she gave evidence to the
Malcolm.
Yeah, that's the one, who gave evidence in Parliament as to the pain that she had and how she was literally wrapped around the toilet bowl in excruciating pain, and was told it was normal. And she went, God, what it was, I can't remember. I remember in the book, but basically it wasn't until she was 47 or something that she finally got a diagnosis. So why, when you describe all of that plethora, depending on how you like to pronounce it, of symptoms, why does it take so long?
Because if you think about the symptoms I've described, and within that I even said, is it painful bladder syndrome? Is it IBS? They're often mistaken, right? Because how many people have all these symptoms? So it can be they can be really non-specific and difficult to diagnose. That's firstly. The other thing, like you've just shown us as a case of that celebrity, is that we're always told, aren't we? Oh, it can be normal to have period pains. Well, it's very subjective pain, right? So often women's conditions are put down to, you must just be, you're anxious, or it's normal to have period pains, just get on with it. So that can be very difficult as well, because it's perceived as, well, is this just your pain is subjective and you're just making a big drama? Yeah, absolutely. So a combination of being so non-specific, as well as the fact that obviously it is a very subjective thing, having period pains. But of course, we know it's not normal. Absolutely, it can be common, but it's not normal to have extreme period pains.
Yes, and we really do need to stress the difference between normal and common, don't we? Because that's always said, is it, it's perfectly normal. It might be normal, but it might be common, but that doesn't make it normal. Yes, exactly.
No, and is it affecting your quality of life? And that's the important thing, right?
Yeah, absolutely. The okay, so once we finally do get our diagnosis, and what do we do to manage it? And as you were saying before, it was sorry, there are a couple of questions there which I'll come back to in a second. But it's individualized depending on what you've got. But in general, I'm assuming there's a progestin element in all of this. What are we doing?
Yeah, so I'm going to mention everything though, Fiona, because I think it's really important, because for everyone, different things do really work. So because it is very much, and I hope that it was helpful me explaining what the process of endometriosis and what happens is, because that is what helps us manage our symptoms. So basically management is based on a number of things: reducing inflammation, or managing your inflammation, reducing pain, reducing blood flow, or also, or symptoms associated with that extreme blood flow, extreme pain around your periods. And that is what helps us try and work out what treatments are needed. I'm going to throw in fertility as well. And the reason I'm going to throw that in is that when you asked me earlier, it is so important. Please do keep symptom diaries, okay? Because it is important that this is not normal. And the earlier you get help, I'm not saying as soon as you have period pains, you have to go and see a doctor, but it's important to keep an eye on it and keep a symptom diary of what's happening to you, because fertility benefits from earlier diagnosis. We all know this. Yeah. Also, not to turn into chronic pain and scarring, benefits from earlier diagnosis and treatment.
Which actually leads to this question here, which I'll throw back in you, is how do we differentiate between inconsequential versus extreme period pain? Is it just the quality of life impact, or is there more to it than that?
It is absolutely the quality of life impact, isn't it? But also it depends on your circumstance in life. So I think quality of life and individualizing care is my number one, as well as being safe, obviously, my number one way of talking to patients. But if fertility is in your life still a priority, that also needs to be there. And what I mean by that, and I always say quality of life, because it is always about how's it affecting you as an individual. But you can imagine why it's different, how someone who's 47 completed their family, your priority is going to be quality of life and what treatments can be just to help you with your symptoms, right, to make you feel better. But if you're 20 trying to get pregnant, that is also a priority. So treatments is going to be based on that as well. So let's go through the treatments then. So if we go through, first of all, as I said, I approach it very holistically. Lifestyle. Why is lifestyle important? Because we're reducing inflammation, right? So with reducing inflammation, a lot of people do benefit from an anti-inflammatory diet. They really do. And a lot of people do say to me that, you know, they'll go and get some personal training or, you know, work around their cycles with their exercise and also incorporate anti-inflammatory, and it really does help. So that's one thing that can hugely help.
And when you say anti-inflammatory diet, you mean, you know, good amounts of fruit and vegetables and healthy foods and things like that?
Yeah, but it's not about telling people just to eat healthily. So actually a lot of chronic conditions, you know, loads of chronic conditions, thyroid conditions, rheumatoid arthritis, all these eczema, asthma, these all really benefit from anti-inflammatory. So what that means is, as well, you know, if I think about, there's lots of different ways of approaching it, but if we use a Mediterranean diet as an example, you're having plenty of your kind of proteins, plenty of different colors, fruit and veg, because that gives you minerals and antioxidants and anti-inflammatory properties. You're reducing high processed foods, because high processed food is high in inflammation. Dairy also, you have to be very careful. Obviously, I'm in that two minds, aren't I, as a menopause specialist, making sure people keep their dairy nice up to keep their vitamin D and calcium up, but also mindful that dairy also can be quite inflammatory as well. So, you know, I've got an article on my website, actually, if it's helpful, it's all free, my resources, but I've done an article about anti-inflammatory. So it's not just about telling people, oh, just eat well and don't go to McDonald's. It's about actually certain foods are very good at anti-inflammatory, and some foods really are explosive for inflammation as well.
All right, good. Send me the link to that afterwards and we'll put it in the notes.
Yeah, sure. And I've lost my trail now. What was the question? Oh, we're up to lifestyle.
You anti-inflammatory diet, exercise, other lifestyle things.
Yeah, mindfulness and CBT. Now, people might cringe when I say CBT because there's been so much in the media, but why is that important? Is because the stress and cortisol is an inflammatory, right? So it might seem really silly, and it really isn't. I'm not saying that alone is going to solve your endometriosis, but some people really benefit from that support alongside other treatments. Everyone's individual, everyone gels with different specialists differently, but some people do tell me they find that really beneficial. And mindfulness is really important because, you know, our stress, our cortisol, our adrenaline, it does actually make us feel worse, and pain gets heightened, right? So I'm just saying this all alongside all the other treatments. Non-hormonal treatments, if we think about anti-inflammatories, we've talked, some people just find their periods are the only time that they get pain. So some people do benefit from tranexamic acid, which is an anti-clotting and anti-inflammatory property, methylamic acid. Some people do fine with paracetamol and ibuprofen. Again, it's individualized, right? You might work on a stepwise, get your over-the-counter from a supermarket. If that doesn't work, you may need something stronger. So again, that's very much individualized. Then we look at hormonal treatments, and this is where I was saying to you, fertility matters. You are not going to tell someone trying to get pregnant, go on the pill, right? But what you might need to have is a balanced discussion about what is your priority, because obviously we know that hormonal treatments, and I'll explain why, may really benefit you more than if you've tried other things that haven't. But of course, if you're trying to get pregnant, then that's not going to be able to support that. Why does hormonal treatments work? So if we think about what happens when we ovulate, from the brain to the pituitary gland, we get our signals, we get our hormone precursors that tell our hormones, our estrogen, our progesterone, to release hormone. I've just said that endometriosis is very much instigated with estrogen, right? So what the aim of the hormonal treatments is, you're trying to down-regulate your pituitary or trying to switch off ovulation. And by doing so, then you're either not going to have periods, at least they get reduced, that bleeding flow gets reduced, or for some people, just switching off their ovaries totally can really help reduce that. So this could be
menopause, or?
Well, it depends. So this could be as simple as the contraceptive pill, be it the combined pill, progestogen only pill, the progestogen implant, the progestogen injection, and then the coil. The coil people have probably heard of as the most common. The reason being is it was also a treatment for heavy periods and painful periods. So people have probably heard of that, you know, quite significantly, right? So
that's not going to address any endometriosis that's outside of the uterus.
Yes. So it's not, and that's where when we talk about HRT will be a real pointer that I'll talk about. And then you've got something called gonadotrophin, so GnRHs, okay? And this is where so from your brain, you down-regulate the pituitary, because what happens is that's your precursor to your sex hormones, gonadotrophin releasing, right? That's your precursor. So what it happens is you're trying to tell the body, by releasing that, you don't need any more. So then it does a negative feedback back to your brain saying you don't need to produce any more estrogen and progesterone. And that's why then your ovaries get switched off. So that is what we call a medical menopause. Okay. And so obviously, so by doing that, you're going to switch off your ovaries. Another way is obviously taking out your ovaries. That's another thing that can happen, right? And alongside that, you may have a hysterectomy. Or for some people, obviously that may not be an option if you're trying to get pregnant, or of course that is quite an extreme option, actually taking out the deposit. So you can have obviously surgery to take away scar tissue, take away the deposit. When I counsel patients, the beauty of having been a gynecologist and a GP is that I've seen it, the whole pathway. I try and make sure that patients are aware of the risk, because don't forget, a laparoscopy or an operation does not come without risk. One of those risks is scar tissue. And I've just described how scar tissue and inflammation is one of the worst things that can happen with endometriosis that results in that plethora of symptoms, right? Yeah. So it's really important patients do understand that, because a lot of patients seek that diagnosis. But I think it's so important we counsel them properly. What is your options and what are we gaining by giving you a laparoscopy? Like, would you still be happy if you knew that we could treat this or manage this without need for that formal diagnosis? Because not only could it cause complications, even though it's the gold standard having a laparoscopy, did you know that actually deep endometriosis may not actually be seen on a laparoscopy? And deep endometriosis represents more severe.
Yeah. God, it's complicated, isn't it?
Really
complicated. I know that you throwing in a shameless plug here, but with my Menopause coming back, which you are featured in, there's a section in there where it starts off talking about misogyny in medicine against women, and it describes a woman from the 1770s or so who had chronic pain throughout her life, and at the end of it, she sort of said to her friend, was a doctor, I want to know what this was. So she asked him to make sure that she had an autopsy afterwards to have a look, and they went through and they found, I mean, literally just this shopping list of things that were in her pelvis, including, there were tubercles, there were fissures, there were cysts that were full of bituminous coloured fluid. You name it, it was in there. But what they really said in there was, her uterus and her bladder were fused so tightly onto the rectal tissue behind it and onto her intestines, and it had to be prized apart with force so they could get in there and get it. But then at the end that they concluded, she was hysterical and she was making it up because the uterus looked okay. Yeah. Yeah. So there you go. It is just one of those things where you just look at it and think, this is just so complicated, and
it's really complex.
What a life of pain.
Yeah. Some people need that diagnosis, but I really like to tell people, or explain to them at least, because I think a lot of people want that diagnosis and aren't aware that having these operations can worsen their scar tissue. And actually, if we can manage you and do everything to try and help those symptoms, and I can tell you, you're not making it up. I think it's delivery, right, as well, communication. If I say to you, you're not making this up, this is likely endometriosis, but what are we going to gain by getting the diagnostics? Are we actually gaining anything? Or would you be happy if I explain everything to you, all the treatment options, try it, and if it works, then would you be happy with that? And I think the communication is key as well.
Yeah, and that's probably quite sensible. Very good question here as well, again, asking, does endometriosis become deep with time if it's left untreated? And why is deep endometriosis more severe in terms of causing pain?
Yeah, good question. I don't know how to answer that, and the reason I don't know how to answer that is you could get worsened endometriosis because, as I said to you, chronic inflammation leads to scar tissue fluid that ends up like you've just described, that person who's just had adhesions. That's why I'm saying you get bladder and bowel symptoms, because everything's stuck together. It could absolutely be a chronic buildup. But when I've actually been at laparoscopy and we've seen endometriosis, we see what we call these gunpowder spots, right? They're little black nodules that you see. So you can see them. But sometimes you have to really look for deep deposits that aren't necessarily coming from the surface. So there's really difficult or no way of me telling you whether they just were there, as in have just appeared there, or whether they have migrated due to chronic inflammation. It's hard to be able to answer that.
We need some sort of system where they do, like, the radioactive dyes or whatever, where we can make them light up so we don't dig around in people's bellies.
100%. And I'm sure things have developed since I was a gynecologist, and actually there is. And if we think about it, we do have laparoscopy and dyes and things like that. So we're looking for tubal patency. They're absolutely, there are absolutely novo or brilliant diagnostics now. And often you don't always have to have a laparoscopy. This is why I'm saying it's about talking to someone, because symptoms alone can be diagnostic. There's lots of different modalities. Ultrasound often is normal, or it has really good, there are signs on ultrasound that can be diagnostic. Like, for example, your womb not moving because it's stuck. Your ovaries are kissing the uterus. That's what it means, because often there's scar tissue and they're stuck together. Adenomyosis is often seen as different. Like in when you scan, you can see, I can't explain it to you, but when I scan, I can see it, that you can just see the difference in the layers of the myometrium and what's happening there. Or you can see like changes to blood flow within that. You can see cysts. So endometriomas are called chocolate cysts. So you can see those. You can see fluid in the pouch of Douglas. So that's in the back part of your pelvis. That's a sign of inflammation and can be endometriosis. And then, of course, there's having an MRI that can also show. But none of these are definitive. And that's why I think it's so important to talk to people.
Yeah, absolutely. All right. So progesterone, does the type you pick make a difference?
Yeah. So this is when we're talking about HRT, right? So this is why it's really important. So for those of you just listening because of the HRT element, let me explain why all of that was important. So whether you're premenopausal or menopausal makes a difference what your treatment's going to be. Whether you've had your uterus taken out and your ovaries taken out or not taken out makes a huge difference of what that treatment's going to be, okay? And so that's why the type of progesterone makes a difference. And the extent of your endometriosis makes a difference as well. So what I mean by that is some people can have endometriosis that might just be adenomyosis, might just be areas within the womb contained, or just within the ovaries. You might just see some endometriomas or chocolate cysts. Some people have extensive endometriosis in their pelvis. And that makes a difference when you have HRT, whether or not you need progestogens or not. Okay, and whether or not you've had your ovaries out, etc., can make a difference about in terms of when we think about endometriosis and flaring up. When we talk about, people will be asking when I have HRT, isn't that just going to worsen everything? So that is where it makes a huge difference.
Well, this was the question from one woman basically saying that she'd been told because she has adenomyosis that she can't possibly have HRT because it's going to make it worse.
Right.
But that may not necessarily be the case if you're right there.
No, you have to carefully balance it. So if we think, so when we're giving HRT, when you've got a womb, most of us know that our estrogen helps our symptoms. Anyone with a womb, we give progestogen, right? Now, when we've got endometriosis, when we've got a womb, the same applies. When we don't have a womb, the same may apply. The reason being, I've just told you, endometrial deposits can be in other areas of the body. If it's very well contained and you can be very confident it's well contained, those people may get estrogen only HRT. But the guidance is to at least provide them combined HRT until menopause. Okay? That's one thing to say. If you've got
actually really important though, isn't it? Because a lot of people who've had surgical menopause and had their uterus removed are always told, well, you don't need any progesterone. But whereas they go on and continue to have this pain.
Absolutely. And so if you've had endometriosis, that's why I'm always very careful to ask, why have you had your hysterectomy? Was it anything to do with endometriosis? And did they find endometriosis in your pelvis or anywhere outside of the uterus? Because that is so important, that the reason you need progestogen is so estrogen can flare up your endometriosis. So in the sense, that's correct, in the sense you need to balance it, okay? You can't just willy-nilly give people loads of estrogen and hope for the best. You have to say to people, it may flare up your endometriosis, firstly. The other thing why we worry is in people who haven't got a womb, who are given estrogen only, but have endometrial deposits elsewhere, you may get, there's a theoretical risk of a malignant transformation. So because we've said anyone who's got a womb needs progestogen to stop it thickening, obviously if you've got womb deposits in other areas of the body, that's the reason you need progestogen. So coming back to your question about the Mirena coil, that is not going to provide you systemic adequate, it works locally, okay? Yeah. So that is where you may need a systemic progestogen.
Okay, because that's it. Because a lady over here on the Instagram has just said she does have the coil, and she's found it actually it has been quite good for the pelvic area as well. But what you're saying is then don't rely on that for protection.
Well, what I'm saying is if you've got extensive endometriosis everywhere, we have to be aware that a coil alone, when you've got a womb, may not be sufficient. Okay, when you're giving HRT. Yeah.
If people are using an oral progesterone, then like
Yes.
a progesterone, then that would be fine. But what happens if like me, they cannot tolerate it orally, and they think, oh well, I'll use it vaginally? Are they going to get the same benefit, or is that not going to work then?
Well, this is the difficulty. There's not enough data or study. I think the problem what we've got is we've got extremely limited data here. So even the studies we do have, we've got studies on people who've had their ovaries taken out, right? In those women, there's a study showing that 6 years on, there was no malignant transformation or any flare-up of their endometriosis when given estrogen only compared with combined. The problem is the data is so limited, and it's not everyone's not just had their ovaries taken out, right? Some people have just had their womb taken out to reduce their periods and have their ovaries left behind, but also some people have extensive endometriosis. So the best thing to do is give people combined HRT to at least the age of menopause, natural age of menopause. Well, that in itself is a question now, because we say it's the average age of 51, but in clinic, I'm seeing more and more people having periods at 56, 57 now.
Yes.
Yeah, absolutely.
Yeah.
Yeah.
Every time I do a survey on things and I put on how old are you and you're still having periods, I get people 59, 61.
Yeah, it's crazy. Yeah. Well, I think like evolution. I'm not. Please, geneticists don't write back and hound me if I'm wrong. But I just feel like evolutionary. We're living longer. We're working longer, right? Fertility-wise, we've not caught up, unfortunately, have we? We can't have babies later still. That hasn't caught up, but it seems to be our periods and all the bad things continue later in life. None of the good stuff. But that was a very complex way of me just trying to say, if you've got extensive endometriosis, I give combined HRT. Another group we haven't mentioned is those who have had a subtotal hysterectomy. So you've had your womb taken out, but your cervix is left behind, right? A trial of progestogen is needed because the womb and the cervix, that's the line. You can imagine if you've got extensive adhesions or there's been any complications, how do you know that you've got exactly that amount of womb tissue out? So if you give someone a 3-month progestogen challenge, take the progestogen away and they don't bleed, because remember in these people, they've still got an outlet, then you can say, right, it's unlikely you need to carry on with progestogen. You can just have estrogen. So that's important as well, that group of people. Yep.
God, we need a flow chart to get through that, don't we?
I know. I hope it made some sense and people aren't feeling. It's a very, very complex subject.
Yeah. Some progestogens are more androgenic than others. If you were looking at somebody, would you then think actually one of these is better for you than one that's less androgenic, or does it not necessarily make any difference?
Right, that's a very good question. So when it specifically comes to endometriosis, no. But let's think about, when we talk about progestogens, there's a whole other thing we need to think about, right? We're thinking about fertility for some people, but also let's not forget the risk of synthetic progestogens and breast cancer, right? There's those things. So with endometriosis, no, not specifically, but when it comes to what your menopause symptoms are, I am very, very much tailored to someone's symptoms. And androgenic progestogens, I'm not going to give to someone who's telling me they've got PMS symptoms or severe headaches, acne, mood disturbances. So it's more about making sure entirety of that patient and what their symptoms, not just their endometriosis symptoms, but their menopause symptoms, but also take into account the type of progestogen you do give. Don't forget there are risks of breast cancer with that as well.
Albeit they very, very, very small.
Yes, absolutely. But it's important people still know, because we've got body identical progesterone. We've got about 6 years of data of unlikely any risk of breast cancer. But synthetic progestogens, what we're talking about is combined compared to estrogen only, right?
Yeah.
Holds up. So what I'm saying is it's just important we take everything into context.
Yeah. Yeah, very, very messy. So when we get, okay, so we've got the estrogen, we've got being a trigger, we've gone through up to perimenopause, then all of a sudden these menopause symptoms do strike. We've been managing things very, very well with our progesterone only contraception or whatever. Now we are being, we're hot sweating until the cows come home and extremely moody and everything else that goes with it. What are we doing?
So absolutely, you can have HRT. Firstly, it's about, again, people are going to, I need a t-shirt saying individualized care, but not everyone wants HRT, right? That's first thing to remember. And that's why I started off by saying, let's go through all the different treatments, because not everyone wants hormonal and some people are happy dealing with lifestyle. And the same applies to menopause symptoms. I would still go through things in your lifestyle that might help you with your specific, depends on what your symptoms, right? We can't class all those symptoms into one category. If you've got hot flushes, my treatments or my suggestions to you would be very different to if you just had vulval vaginal dryness. So it's important about, again, individualizing the symptoms. So again, lifestyle plays a huge factor. There are non-hormonal medications. So if you're having hot flushes, you may decide, I don't want to have HRT as well. Or, of course, there is the option of HRT. Now, I prescribe HRT for endometriosis, but it's important that we just balance that, right? And we have that knowledge. Actually, it could trigger it. If it's important we give you combined HRT. If you do get pelvic pain, we need to think about that. So it's just important that that is in the back of the mind. That is not a reason not to have HRT and to suffer either.
Yeah. Two questions out of that. One, because I forgot to ask before, and as when you say combined HRT, is it better to have it continuous or does it not matter? As in, can you have a period if you want one, or do you have to, is it better not to have a bleed at all?
Yeah, so this is, we're talking obviously perimenopause. The guidance says to have combined. Now, if you think about why, if your periods are causing you pain and also bleeding, and then it's better to have something that is continued, which is why the Mirena coil perimenopausally can often be better, because actually you're not then getting erratic bleeding if you try and put someone on a pill every day, right? Or the Mirena coil is a good idea. We forgot to talk about other options like Tibolone. That is an older style. Yes. Obviously there's Tibolone that can be used.
Fezolinetant and the other new one whose name I can't remember.
They're non-hormonal medications, those ones, the Fezolin. So they're the non-hormonal. But when we're talking about hormonal, we've got your HRT, your estrogen, your progesterone. We've got Tibolone, which is it's basically a synthetic steroid that has estrogen, progesterone, and testosterone properties. So that's another option. And then there's newer treatments you might have heard of have come out this year. I can't ever say them, I'm sorry. Rigolix is one of them. So it's a GnRH antagonist that contains also in combination, one combination pill, estradiol and northisterone. So your GnRH normally are injectables or nasal sprays. And with that, you have to have HRT because it switches off your ovaries and sends people into menopause, right? Yeah. And so that's why you would then add them. So these newer pills are also available as a hormonal treatment for those that are experiencing endometriosis in a combined pill.
Yeah, yeah. And the actually, before we get to non-hormonal, the other question then is, okay, given some testosterone can be converted to estrogen, if people have, say, low libido and they're prescribed testosterone, can they have that happily?
Yeah, absolutely. You can have testosterone, but you just have to be mindful that testosterone is peripherally converted to estrogen. So again, it's just having that conversation, having that balance.
So if perhaps you'd had because I know that there are so many times when people say, oh, nobody told me that, I didn't know I have to have it. So let's say you've had your uterus removed and they're saying, well, you don't need the progesterone because you've had your uterus, because these things happen. And so you're not having any estrogen, but you are having testosterone, to then ask your doctor, do I need a progesterone as well to go with that?
Yeah, so it will, I mean, why is somebody having testosterone without estrogen though? That would be the other question. Because that's the other thing. Testosterone is converted to estrogen peripherally. Yeah. So, normally we give testosterone when you're having HRT or you're having estrogen that hasn't helped your libido or your other symptoms. And then for the right reason, you would then add in testosterone. Why it's important to do one thing at a time as well, by the way, is because testosterone is converted to estrogen, they just compete for receptors. And I'm a big believer, if we do one step at a time, let's get your estrogen deficiency symptoms sorted. Then let's add testosterone. But also these women, often their ovaries are taken, right? And the younger you are, if you've got endometriosis and you've had your ovaries taken out, the more likely you need higher doses. the more likely you need testosterone as well. So this has to be a very balanced conversation. And I'm really sorry if it sounds very complex and all over the place, and it is. But I guess what I would really simplify and say to you is that there's lots of treatments, including lifestyle, non-hormonal, hormonal. Your fertility plays a huge part of whether that should be what treatments you'll get. But of all the different hormonals, there's lots of contraceptives, there's HRT, there's tibolone, and there's GnRH, and lots of different new preparations as well. So there's a whole host, but it really needs to be individualized by taking a proper history from someone.
Yeah, gosh, absolutely. Yes, I feel like we've just sort of taken a bucket of mud and thrown it on the wall. That's a lot of very, very complicated stuff, isn't it?
Yeah, absolutely. Yeah.
Wow. All right. So take-home message, though, is that basically, whether it's adenomyosis or endometriosis, you can have your HRT.
Yeah.
You need to have adequate amount of progesterone or a progestin to balance that and manage it. And there are other factors that come to play in it in terms of lifestyle, anti-inflammatory diet, exercise, mindfulness that you mentioned, CBT for some people, just in terms of the sort of external management of the pain and things. Whew, does that sum it up?
It does. If anyone's feeling really overwhelmed, like, gosh, that was so much information, just take home from this. Look, keep a symptom diary, be proactive, okay? And also just really seek help early. I don't mind when people come to me in my GP surgery to seek help early. The important thing is that you are listened to and all the options are given to you. Now, I might take 2 consultations. You know, we've done this in a session like this, and I've been told almost like regurgitate everything about endometriosis. And I hope it wasn't too complex in the sense I did try and break it down, but I appreciate it's really, really complex. But really the take home is keep your symptom diary, do the things in your lifestyle that are in your control, seek help from your doctor early, and then there are non-hormonal and hormonal options. And HRT absolutely is not only, restricted, it is absolutely an option. I have lots of patients on HRT with endometriosis. It's just about being safe and going through the different types. If you think about, we're giving a generalized webinar, I'm not going to sit here and overwhelm patients in my clinic with all of this. I'm going to, depending on what their own situation is, right? If they had a hysterectomy and ovaries, I'm only going to talk to them about that specifically. Whereas we've just tried to cover it for everyone, for everything, which is why it's a bit of a, mind.
Yes, a mind blow. The other, all right, just I'm going to get quite graphic here. So if people have got queasy stomachs, turn away now or block your ears. If you're keeping a symptom diary, and I guess this is really important too, especially for people who are quite young, who are continuously told, oh, it's just normal. What sort of things can they put on them? Can they put on them? How heavy they're? Because this is the other thing too. People say, well, how many times? It also all seems to come down to, well, are you passing clots? How many times are you changing your sanitary devices? All of these sorts of things.
Yes.
I think the kinds of things that they should be putting on their symptom diary, how often they have periods, how should they put a rating scale of 1 to 10 of how much it impacts them, how many times they're wrapped around the toilet bowl feeling nauseous. What should they put in those diaries?
Yeah, and look, if you think about it, when we talk about heavy periods, I can't even remember what the figures are because I'm going to be really honest, I ignore them. There is actual objective measures of what heavy periods are, right? For me, it's a has your period changed from what you would class as normal to changing? That is.
Can you imagine people sitting over a cup for 7 days, measuring in mils how many?
I know, it's crazy. Exactly. So for me, like, look for, symptoms are things different for you. But also you're absolutely right. Just write anything down that's important to you. It is so heavy that I soaked through blah, blah, blah. It is so heavy that I felt faint. But if you are having those symptoms, you need to seek urgent medical help anyway, because any signs of anemia, so like palpitations, chest pain, where those are important, those big clots, soaking through a thick pad more than 1 hour, that's a sign of that's going to turn into severe anemia. That's why that's really important. But in terms of your symptom diary, yeah, how's it affecting your quality of life? Absolutely. But also, are there things that you find that are helpful? Are there things that you've taken that do work? Or are there things that you've taken in the past that just don't take the edge off anymore that used to? Or are there things in your lifestyle that you find are helpful? Because these are all really helpful, right? To be able to create a plan for you that actually might work for you yourself.
Yeah, that's a good point, actually, isn't it? The things that help, isn't it? Because then you can amplify those, probably give you a better idea of where you're taking somebody and that whole lifestyle. Yeah, that's actually a very good point. We don't often think about the positives.
No, but it's not trying to say or be positive about it. It's just we need to think about solutions, right? Not just the fact that this is happening. How can we now try and help you manage this and solve it? And so a huge part of that is actually what things in your day-to-day will be helpful for you.
Yes. Sorry about the siren going past, but I will just share a very, very quick story with you. I'm hoping that that's the police. However, I'm thinking it's probably the fire brigade, because we just got a message from our building manager saying, don't be alarmed, but a group of travellers have moved into the building site next door and taken the building manager hostage.
Oh.
And apparently the police are refusing to come because they're dealing with something somewhere else. And I'm thinking, there's a man that's taken hostage next door and the police are not coming. Okay.
But it's okay because you've got your HRT and your estrogen next to you.
That's true. I'll just go and squirt them with a tube of estradiol, and that'll have them running.
Yeah.
Yep.
I'll bring this. That'll have them running. Yeah.
Exactly. Is there anything else that we need to say while I walk away? And I think, my God, we need to do a flowchart. What else do we need to do to someone?
Well, what are the people listening saying? How do they feel about it?
Well, there were just those questions about how it really worked and what it did. They were about I've asked you all of the ones that popped up, really.
Yeah, I think I know it's overwhelming, but as I said, everything's individualized. So you're not going to go through all those treatments. What the take home here is HRT, absolutely, you can have if you need it. You may need combined, because even if you don't have a womb and you've had endometriosis, there are areas of deposits there. Take a very holistic, holistic as in everything that can help you in your life. And I always am very nosy in people's lives. What can we do to help all of those symptoms? And there are lots of different hormonal, non-hormonal lifestyle treatments available. But I think the real take home for people is that don't be scared. You will not have to suffer with your menopause symptoms if you go to the right person. Absolutely, you can have HRT. It's just balancing it well.
Yeah, absolutely. Hang on, just let me do something here for a sec. I just forgot to do that before. Let me come back to you. Where are you? Yes, there we go. Great. I think we're sort of covered then, aren't we?
I think so.
Excellent. So on your website, send me the links, but also just tell people what your website is now, so that if they want to, they can go there and they can see your resources. And also, then I can probably go on and grab the links anyway, but you'll probably know better which ones are the right ones that you sort of want to share. So what's your website? Where do people find you?
Yeah, so it's obviously you can see my name. It's Dr Shilpa McQuillan, and it's Berkshire Menopause Clinic. And I've even written a article on endometriosis as well. So we've got lots of free resources on there. So have a look at that. And I've also got a YouTube channel as well, which is Berkshire Menopause Clinic. And please do follow me on Instagram and Facebook, because or LinkedIn if you want to connect on LinkedIn, because I have lots of videos I do when new treatments. So when the relugolics came out, I did a video about it. Any endometriosis, I've been on Radio 2 recently talking about endometriosis, the impact it has. So yeah, follow me and hopefully you'll find it useful.
Brilliant. Thank you so much. And I will end this here and I will speak to you soon.
Bye.
Bye.